All right, so moving along, we're going to look at OT services in the criminal justice system. So this is not a step down, it's a side step, okay? Interestingly, the criminal justice system is often the largest provider of mental health services within a particular state. They are often the first exposure people have to assessment and treatment. So imagine if you have an undiagnosed mental health issue, you may be moved to eventually interface with the criminal justice system, and then at that point you get some care, you get diagnosed and evaluated and diagnosed potentially, and get some services. The length of stay really varies, and goals are around symptom management and life skills. The team consists of a correctional officer, social worker, attorney, psychiatrist, a probation or parole officer, and a case manager. And OT doesn't have a standard role in criminal justice system, but more and more it is an alternative environment for practice and an emerging environment for practice. And so we're seeing OTs move into the jails and prisons more and more. So pretty exciting. Settings, it's not just jail or prison, although it includes that, but juvenile detention facilities for those who are under 18, diversion programs, which are often a youth really is getting into a lot of trouble and is headed for jail or prison. And so these programs are kind of a stopgap and a way to hopefully, as they say, divert that individual from more serious consequences. Also, probation and parole collaboration. So, a person may not be incarcerated, but is under the mandatory care of a parole or probation officer. Jail, and how we differentiate jail from prison, is jail is a place that one would go for less than a year, prison greater than 1 year. And then prevention programs. So, for example, a drug and alcohol program that's remanded by the courts. All right. So the role of OT in these settings. Definitely we're going to be engaged in assessment. Again, collaboration and advocacy is one of our roles, and we would collaborate on sensory needs slash self-regulatory needs, on socializing, general programming, and then modifying routines. So we're going to look at the larger scale of life and what that youth is engaged in their daily life, and how can we switch that up so that the choices that they're making are more adaptive and effective for them. Intervention would include social skills, leisure, exploring their interests. So again, remember, these are teens. If they've gotten into some trouble really early, they may not even know what they like or what they enjoy. Same goes for employment and education. They may not know what they're interested in or what they'd like to do. So supporting them in exploring it and also accessing employment and education can be a role for us. And then IADL. So moving from being a child who is more dependent to being in an adult role and needing to take care of one's instrumental activities of daily living. An example of this is, again, OTTP, and they have kind of two parallel tracks. One is from juvenile hall, and they do groups, they provide advocacy, modeling, and also hope that this is not the track that you're on and you're on a railroad, you're on a train and you're not able to get off. So there's really a lot of attention to opening up that person's hope and showing them that they do, in fact, have some choices. The other track, if you will, is Community Assessment and Referral Center, and also the Adult Probation Department. So within these settings, there's employment help, again, advocating for the client, interest exploration, and working on self-efficacy. Next up, we have supported housing and community residential programs. When we're thinking about community residential programs, we think that the supported housing and ongoing case management for clients can help, especially folks with chronic mental illness, and it can provide just enough structure so that they are able to remain in the community. Housing can be short-term or long-term, up to permanent. Case management services include a connection to resources, various methods for assessing the client's needs, arranging support services, monitoring medication, again, that all important, let's keep that person stabilized, and advocating for the client. The role of OT in this setting is to work with both the client, who's called a consumer in this setting, and the staff to develop and implement structured daily activities and groups. So we're going to provide some more structure beyond just the housing structure. We also work on building life skills, raising one's insight into their life and their situation, engaging in expressive therapies, wellness routines and activities, and socialization skills. Recovery-oriented services are also sometimes oriented and are offered and are designed to ensure that consumers remain stable in their community. So we want to, as much as is possible, support the folks who are living in community residential programs to stay clean and sober or engage in harm reduction, whatever is appropriate for the particular setting. And they have different requirements so that they can remain stable and remain in the community. Another aspect or perspective on stabilization. An example of this is Front Street Inc., which is in Santa Cruz, about a half hour south of San Jose. And there's 24/7 supervision. There's initial assessment and then ongoing evaluation of the residents. It's a fully integrated wellness program, so they provide everything. And there's activities program, medication assistance, skill development, assistance with community integration, and stress reduction activities. So the Front Street Director of Community Service is an OT and supervises the housing support. The team provides case coordination, medication support, as I said, OT, and assessment and selection of the folks that would be wanting to move into the environment. Here's just sort of an example of the types of groups that would be provided, and some of these, if not all of them, could involve OT, especially if they were adequately trained. So again, medication management, stress and anger management, interpersonal skills, you're getting a theme here, right? Community integration, nutrition and fitness. So when one is living on their own, we want to include balance along physical lines as well. Recreation and leisure, substance abuse management, and social skills, so both friendship and intimacy. Oops. All right, so we're getting to the home stretch here. Some general information about the continuum of care for folks with mental health issues, and especially youth with mental health issues. The role of OT is to facilitate the individual getting peer support, either individual peer support or peer support through an agency. Also to support and respect the client. Our clients often have been through a lot, right? And they don't present real well, especially to start with. And so having that support and respect can be very crucial. Also referring them to other services as needed, collaborating with teams, and consulting on cases, again in our scope of practice and the areas that we are particularly skilled in. We also want to attend to understanding the system. So within any system, including the mental health system, there are the players and there are the parts and pieces, and the better knowledge we have about how all that works, the more effectively we can advocate for and support our clients. So who are the players in this system and how do they communicate with each other? Is there a psychiatrist or a psychiatric nurse practitioner? How do they communicate? Is it a team meeting? Do people email? Is there a shared doc? Like what, is it once a week, once a month, every day? So knowing all of those things can be very helpful. Also, who are your allies? So who are the folks that are within that system and on your team who are really going to be on the same page with supporting OT's efforts? Are there potential conflicts? So sometimes the criminal justice system or a hospital system or other systems, I'm just making an example here, may not have the same goals and priorities as we do. Not because they're bad and we're good or anything, but just because they have different priorities, right? So, for example, a criminal justice system, their priority is keeping everyone who's not within their institutions safe, whereas our goal is also to keep our clients safe and going back into the community. So you can see how a potential conflict may arise. Not necessarily, but we want to be on the lookout for it and be alert to it. How does the funding work? So like everywhere else, the services, the duration, the intensity, who's on the team, all of that is going to be in some way beholden to the pocket of money that is available to help clients who are in a particular program. Finally, what supports exist for the clients now, and how about when they complete services? So we're not only interested in what can we do today or next week or however long the length of stay is for a program, but also what's the support and how is the transition facilitated and how is the person helped as they move into another layer of treatment or another facility or another housing arrangement. All right, this is called Advocate for More. There is often not enough for those who are dealing with mental health issues. So we want to identify potential areas for OT, gather data on the efficacy of existing programs, and stay up on the latest research and evidence-based practice and evidence-informed practice. So we want to be really informed practitioners so that we can, incorporate lessons learned from other fields, for example, incorporating trauma-informed care into OT very actively and proactively, and also so that we can network, get creative with funding, and advocate for the expansion of services. OT tends to have a little bit of reluctance in advocating for our services and really being out there pushing for services as a profession. And the more we can really step up to that challenge, the better for our clients. Some additional settings we didn't really delve into are homeless shelters, transitional housing programs, so a temporary housing situation when a person is in between settings, and then refugee resettlement organizations, which are provided for folks who are either entering the country as immigrants or as asylum seekers and don't yet have personal housing. A few tips on OT with transitional aged youth with regard to treatment settings and continuum of care. The ideal approach, and you all know this already, is collaborative. So partnering with our youth, they're teenagers, so we need to consider their age and stage of development and the fact that they are spreading their wings, and independence and making their own decisions is really important. So keeping client-centered, keeping collaborative can be very important. Build connections with natural supports for that person. Collaborate with families, not only birth families, but also families of choice, and work in a team with that individual. We want to work on the client's chosen goals, even if we may not think, oh, maybe that's not the best, maybe it's not the one I would choose for them. It's very important that we work on their goals and build rapport with the person, right? We also want to stay strengths-based, so provide opportunities for them to lead and them to teach and them to step up. So we're not 100% focused on all of their issues and problems and trials and challenges, right? We're actually going to be fostering them as a leader and as an independent, budding adult person. We want to engage in trauma-informed care. So that involves establishing clear boundaries about what we can do, what we can't do, when we might have to report to a governing body about abuse. We also want to maintain respect with that person, manage our expectations of what they can do, and also their expectations of us. Keep your word. So it's super important that you be a reliable and just a solid person. When we're engaging in trauma-informed care, we are meeting with young people who've had a lot of people flake out on them or abandon them or disappear or not do what they said that they were going to do. So we need to keep our word, be consistent, and be really genuine about the whole thing. So authenticity is very important. Finally, it's important that OT engage in our own self-care. We need to, as much as possible, and this can be very challenging work, so not take things personally, that we did something that somehow impacted our client's success or lack of success, or what they're willing to do or not willing to do, how they might talk to us, how they might push us beyond where we want to go, etc. Also remember that you don't need to know everything. You can say, you know what, I'm going to get some more information on that and I'll report back to you. Then you need to follow up with that and report back. However, you don't need to know everything. None of us do. That's the best kept secret in OT. None of us, no matter how long we've been in practice, know everything. And finally, and this is a little bit of an allegory, put on your own oxygen mask before helping others, right? So we hear it on an airplane, and it's really important in working with youth and with mental health conditions, and in general, working in OT. We need to take care of ourselves, so put on your own oxygen mask before we actually are able and capable of working with others. Otherwise, what happens is we're not as effective as we could be, and we burn out. So please, in all things OT out in the community, take care of yourself first so that you can be the best OT for your clients. Couple additional considerations, and we'll be looking at some videos in class, but they're also listed in your presenter notes. So sometimes what will be offered in a community setting is something called harm reduction. And harm reduction is an approach to managing drug and alcohol dependence or addiction or abuse. And rather than having an abstinence program, right, so the person is either using or they're clean and sober, harm reduction suggests that any steps that are positive towards reducing the damage or the danger of being engaged with drug or alcohol use or abuse is a step in the right direction. So folks don't need to be clean and sober in a harm reduction program. They need to simply be working on reducing the factors that are super risky. And again, we'll be watching a short video. You can watch it on your own if you'd like some more information, but I wanted to bring it to your attention. The other thing that I want to bring up to your attention has to do with microaggressions and insidious trauma. So microaggressions, which you may or may not have heard of, are the small things that people say in the course of everyday life that are offensive, biased, prejudicial, discriminatory against people of color, women, the disabled, the elderly, youth, right? All of our at-risk groups. And it's not that the individual who is saying these things means harm, yet it's harmful. It's painful, it's harmful, and over time, even though we call them microaggressions, they pile up to be actual aggressions and really beat down the person who is on the receiving end. So as much as is possible, we want to educate ourselves about that and insidious trauma, which is like those little digs that cause trauma. And again, over time, build into big trauma that is really, really painful, damaging, difficult to address. So we want to be aware of these things and educate ourselves, get input where we need to, and be sure that we are really filtering ourselves so we are not bringing this to our clients. All right, so here are some references for you, and I thank you for your attention. Congratulations, you've made it to the end of the lecture. You've made it to the end of the presentations for this semester. As always, we will be talking about this topic in class. If you have any questions, please jot them down, bring them to class. We'll discuss this and anything else that you need some clarification or more information on. And I hope you have a really great day. Thank you so much for your attention, everyone. Bye-bye.